My name is Kirk Geyer, and I'm the General Manager of Biomedica Diagnostics. On behalf of the Biomedica team, it's my pleasure to welcome you to our series of scientific discussions with key opinion leaders in the field of thrombosis and hemostasis. I hope that you will find these topics both informative and stimulating. At the end of each video, you will find an email address where you may send us your comments and opinions. We would also appreciate your suggestions for future topics that may interest you. Now, on behalf of Biomedica, please enjoy.
Hello and welcome to Coag Conversations, an educational series sponsored by Biomedica Diagnostics of Windsor, Nova Scotia, Canada. Our topic for this three-part series is alternate warfarin monitoring when the prothrombin time is unreliable. We will focus on anticoagulation management, primarily in antiphospholipid syndrome. I'm George Fritzma, faculty for the University of Alabama at Birmingham School of Medicine, Division of Laboratory Medicine, and proprietor of the Fritzma Factor, your interactive hemostasis resource. We begin this first conversation with a discussion entitled Antiphospholipid Antibody Pathophysiology and the Lupus Anticoagulant Test Protocol. We welcome Nicole Zantek, MD, PhD, Professor, Department of Laboratory Medicine and Pathology, University of Minnesota Medical School. Dr. Zantek is a pathologist with expertise in transfusion medicine and blood banking. She is the medical director of the Special Coagulation Laboratory and conducts research in the areas of hemostasis, transfusion medicine, and blood utilization. She is interested in general issues surrounding hemostasis test performance, utilization, and interpretation. In particular, she is exploring how medical circuits, such as ventricular assist devices and apheresis cell separators, influence hemostasis in adult and pediatric patients. Dr. Zantek is also interested in advancing transfusion medicine and blood utilization practices. So let's start out in our conversation, and I'll ask Dr. Zantek to take over and describe the family of antiphospholipid antibodies and their protein targets.
Thanks for the invitation to speak. So the anti-phospholipid antibodies are the five major ones are lupus anticoagulant, anticardiolipin, which is IgG and IgM, immunoglobulin G and immunoglobulin M, and anti-beta-2 glycoprotein 1, immunoglobulin G and immunoglobulin M. And they represent a group of antibodies that are directed against phospholipids, generally in complex with a cofactor, which often is beta-2 glycoprotein 1 or prothrombin. So the way it's thought that these work is that when beta-2 glycoprotein 1 is exposed to phospholipids during, for example, platelet activation or inflammation, it opens up a conformation and exposes an antigenic site. And that cryptic antigenic site is typically in domain 1 of the beta-2 glycoprotein 1. And this is where some of the antibodies can bind. And that kind of locks the structure of that protein. Also, other things can open up the beta-2 glycoprotein 1 as well, like oxidative stress. And when those beta-2 glycoprotein 1 and antiphospholipid antibody complexes are formed, then they can bind to cells, endothelial cells, monocytes, platelets, neutrophils, and thereby going on to activating them. And this process can be further perpetuated to cause injury to endothelial cells, Endothelial cells produce nitric oxide, and beta-2 glycoprotein 1 binding can also disrupt this nitric oxide production, leading to increased oxidative stress, which further perpetuates this process. Complement can also become involved and initiate processes downstream from complement cascade, as well as there's thought to be other mechanisms that antiphospholipid antibodies can work through like such as activating protein C and downregulating tissue factor pathway inhibitor. Ultimately, the thrombus formation is thought to be kind of like a double hit, that a patient has an antiphospholipid antibody and then they get some sort of stressor that triggers a response, and then the antiphospholipid antibodies just make it a bigger response to what otherwise would be a small response. The antibodies themselves, the cardiolipin is one of the targets that's commonly checked for, and that's actually a phospholipid, and it's typically found in mitochondria. And then the lupus anticoagulants typically target phospholipids and interactions with either factor 5 or 10. And it interferes with the ability of factor 5 to be activated by factor 10 or to compete with factor 10 for phospholipid binding to prothrombin complexes.
Thank you. And in talking about lupus anticoagulant, we have a fairly complex testing protocol. What is the most recent, most current lupus anticoagulant testing protocol that we use to identify lack?
So their lupus anticoagulants are detected by their ability essentially to interfere with coagulation testing. And there's several guidelines that have come out. There has been most recently International Society for Thrombosis and Hemostasis in 2020, and then with some sort of informative updates since then, but not really a change in the protocols. And then the British Society for Hematology published guidelines more recently as well. And the Clinical Laboratory Science Institute also published guidelines on how to perform testing. And they differ a bit, but the ISTH is the main one that's used around the world. And the ISTH guidelines and the CLSI and British guidelines all based on a sort of a three parts, that there's three parts to this testing. The first is that there's a screening test that's phospholipid dependent. And generally, those guidelines recommend using the dilute Russell Viper venom test, and then a second test, which is often a lupus anticoagulant responsive activated partial thromboblast enzyme, or a PTT. And ISTH recommends that it's silica-based, but other tests can be used. But it's important that you use at least two of them, because you can miss an antibody if you only use one. And so using two different methods increases the detection of a lupus anticoagulant. So in the ISTH guideline and all these other guidelines, you will run that screening test that's lupus sensitive and phospholipid dependent. And if it's elevated, then you would go on to do the next steps. In the ISTH algorithm, the next step now is to do both the mixing study and a confirmatory study. So a mixing study is done by taking the patient's plasma and mixing it with normal pooled plasma and looking to see how it affects the clotting time. If it corrects it, and there's different ways to measure or determine that it's corrected it enough, but if it corrects it, that suggests that it's probably a factor deficiency that is involved. And if it doesn't correct it, then there's something inhibiting it. And it might be a lupus anticoagulant. You need to do more testing to resolve why the mixing study didn't correct. And sometimes even with mixing studies with lupus anticoagulants, you can see the mixing time prolong as well. And then the other part is a confirmatory test. So if the clot time is long with the phospholipid dependent test, a confirmatory test to see if that prolongation was due to phospholipid inhibition. So it essentially repeats that similar screening test with additional phospholipid, and there's a variety of sources of phospholipid that can be used. Platelets as a source were historically used, as well as other phospholipids like hexagonal phospholipids. The addition of the additional phospholipid should cause the clot time to decrease if it was the cause of if the lupus anticoagulant was the cause of the prolonged clotting time. And so one would look for that to be shortened, and that would cause a positive result. So if the screen is positive, the mix is positive, and the confirm is positive, that is positive for a lupus anticoagulant. Where the CLSI algorithm, which is older but is still used by many laboratories, differs is the order of the testing. So the order with the CLSI uses the screen is, if that's elevated, then actually you perform the confirmatory test.
Mm-hmm.
And if the confirmatory test is positive, if there's not thought to be factor deficiency involved, then it's positive. And so the mix doesn't weigh into the positive decision in the same way. If the confirmatory test is negative, then one would go on to do the mix to see if there was some other evidence of inhibition as the cause of the prolonged screening time. So they too differ in that sort of stepwise process. The other thing that's important with using these protocol algorithms is to really making sure you understand the specimen and when it was collected and things like that, so that you know if it's essentially a good result. And there are times when pre-analytical things that can affect testing as well. And anticoagulation is an important factor in affecting results. And so there's a lot of issues with testing while patients are on anticoagulation.
Okay, yes, let's go into a bit more detail on any of the pitfalls or problems that are associated with lupus anticoagulant testing. And also, I've found many times people think that when you run two assays, one PTT based and the other DRVVT based, that they are meant to be confirmatory for each other. Is that correct?
Nope, they're independent. So they either one can be positive, and then they would be positive for a lupus anticoagulant. They both could be positive, one could be positive. The dual testing is just to increase the likelihood that you will detect it, because lupus anticoagulants are very heterogeneous. And so any single test may miss an antibody, even though it's there and having a clinical effect. The confirmatory test should run through the same line. So if the DRBVT screen is elevated, and then the mix and the confirm test should be all run with the same related reagents. And that's one of the pitfalls sort of in some of the commercially available testing, is that there aren't always reagents that run like this. There isn't a matching screening reagent to the confirmatory test.
Yeah. And the specimen, what can go wrong with the specimen?
Well, it's important that it's collected at the right time, because a Coag is not forgiving when it comes to pre-analytical things. So it's important that it's collected at the right time. So testing during the acute phase situation, like they've just come into the hospital with a situation, can cause elevated factor VIII levels. It can be associated with elevated C-reactive protein levels or CRP levels. Both of those can influence the results. Factor VIII levels can shorten PTTs, for example, and CRP by itself can cause positive reactions in some, particularly PTT-based methods. Also in that acute setting, if there's an acute clot, you get the influence of having things be consumed by what's going on in terms of clotting. So the level may be different than it would be at a more stable state. The other common thing is that we see patients on anticoagulation when they have their specimen collected. And many clot-based tests pick up anticoagulants in them. And so that can cause false results. And sometimes it could be false positive, sometimes it can be false negative. And there's data that indicate that you can see both, so it's not always in one direction. Some tests are more sensitive to particular anticoagulants than others, but the presence of having an anticoagulant can be, lead to false results. Other kind of things are just like processing the sample. What we need to make sure that the specimen is processed properly to before it's frozen, if it's going to be frozen, because platelets are a wonderful source of phospholipid, and they were the source of the phospholipid used in tests like the platelet neutralization, which is a type of confirmed test. So the specimen needs to be processed adequately to assure that there aren't residual platelets. So typically guidelines recommend that they're double centrifuged. And if that's not done, you can get false negative results as well. And so there are other kinds of things that can be problematic with lupus anticoagulant testing is, as I mentioned, the anticoagulants. We are in an era now where we're starting to see things introduced to try and get around some of those anticoagulants. So heparin is one anticoagulant that is common to encounter, and some reagents contain heparin neutralizers, but they will only heparin neutralize to a certain amount. There are ways to treat a specimen to remove it if the reagents themselves don't have it, but again, it will still only reduce a certain amount. The warfarin causes another vitamin K antagonist causes a factor deficiency that can also contribute to false positives and false negatives. In the past, people have suggested, well, you can mix the sample with normal pool plasma to correct that factor deficiency, but that doesn't fully correct the issue and also dilutes the sample, so you may get false negatives just from that step. And more recently, we're seeing lots of the direct oral anticoagulants. So the drugs like rivaroxaban and apixaban. And so we're seeing a lot of that in samples that are sent for lupus anticoagulants. And there's reagents that are being used by some laboratories to absorb those drugs so that you can proceed with testing. But it's important when you do these kinds of treatments to make sure you test before and after to see what the effect of that treatment was. Did it remove what you expected was there? And even when you do those treatments, there's always still a potential for false negatives and false positives. The other issues that can come up with lupus anticoagulant testing is that dependence on a mixing study. So mixing studies can be helpful to identify, oh, it looks like it might be an inhibitor, it looks like it might be a factor deficiency, but there's false positives and false negatives. So sometimes with the mix, weakly reacting lupus anticoagulant is not detected because you've diluted it. It doesn't correct the effects necessarily of a direct oral anticoagulant or heparin. And there's data to suggest that they don't always give you the results you expect. So Bob Goslin and a group of investigators sent out samples to 20 labs. I expect this to be an inhibitor. I expect this to be factor deficient. I expect this to be normal. And then they sent it around to all these labs and had them tested. And they found that no test is perfect, and all the samples had some lab miscall it. Even if you did different methods to determine if the mixing study corrected or not. So those issues with mixing studies can lead you to go down a wrong pathway with lupus anticoagulant algorithms.
Several years ago, I ran an informal survey in Fritzman Factor asking how people manage their mixing studies and particularly what they use as the cutoff for what you would call inhibition or correction, and probably got responses from 70 or 80 different organizations and learned that there's 70 or 80 different ways to do this. And and you can really start a good argument you get to a meeting and you ask people what's the best way to do a mixing study.
And there you'll get different answers, and even the same what works best for one method or one assay may not work the best with different reagents and that, so you'll get different results. So
Yeah,
they're very controversial, I would say. So,
they are. And there's been efforts made to standardize and harmonize mixing studies so far. None of them seem to have worked, but it's an area where there's still some progress to be made.
there is.
It does bring up this question. Besides the clot-based PTT and DRVVT assays, are there other efforts that have been made that can perhaps bypass some of these problems? I mentioned or thought about for a while, there was something called the Taxterin-Ekarin ratio. Is there anything like that that you are seeing or that you're using?
Beyond the ways to get around anticoagulants like heparin neutralizers and DOAC absorbents, there is some suggestion that using a test like the Textrin Ekrin or typing Ekrin clotting time ratios might help get around at least warfarin effect or vitamin K antagonists. So both these are our clot-based tests based on snake venoms. And the venom for the Texturin test is from an Australian eastern brown snake, and the Taiping venom is from the coastal Taiping snake. And both of those venoms used in a clotting assay are phospholipid dependent. And they both activate prothrombin. And then it's compared to a test that also uses snake venom. So the Ekrin clotting time, which is from the saw-scaled viper, that venom also converts prothrombin, but it's not phospholipid dependent. So Ekrin converts it from prothrombin to mesothrombin. And so what is done is that you run either the Taiping snake venom clotting time or the Texturin clotting time. And if it's long, then you would compare it to the Ekrin clotting time and calculate a ratio. And if it's phospholipid dependent, and that's the driver of then the Ekrin clot time should be essentially normal, and the other two would be elevated. But even still, both of those tests get around some of the things with vitamin K antagonists, but they're not perfect. And there's some recent data that suggests that even in anticoagulated patients, you can see a higher rate of positive than and if you come back and test when they're off anticoagulation. So it doesn't get it perfectly around, but it might get us closer to getting around anticoagulant effect. And these tests still have some interference, things like fibrinogen affect some of the testing, and direct thrombin inhibitors and so forth. So no Coag test is perfect, but there are tests like that that are a strategy to get around, particularly in this case, around vitamin K antagonist effect.
Yeah. Well, it appears to me that there's still work to be done in lupus anticoagulant testing, that what we're doing is it works fairly well with especially if we know the patient's situation. However, it seems as though there's still plenty of room for improvement. Well, I want to thank you and appreciate the talk that we've done regarding all of the testing that we do for lupus anticoagulant. And this then ends the first of our 3 presentations on the subject area of alternate testing, particularly in antiphospholipid syndrome. Please come back next month, and the second presentation will be discussing the antiphospholipid syndrome and anticoagulation. Thank you very much for attending.